Okay, so thank you very much for your invitation. So you were very bad with me because I'm the last one. So after the wonderful surgery, I've seen it's very difficult.
You saved the best to last.
I was impressed by stereoscopic surgery, mostly in COVID time. So, but I will try to do my best. So thanks, Kate. Thanks, Charles, for your words, and thanks, Roman, for launching my video. So I will have the control. Okay, perfect. So you know that today, as Chuck said, I'm going to present you some procedural and technical aspects of hysteroscopic surgery at COVID times. I hope that I can give you a positive message. So it's time that we come back to normality because we need even in surgery. You know that the tremendous worldwide lockdown that we had, I hope that the video is really stopped. So okay, now I launched the video. So you know that we had a tremendous worldwide lockdown, and probably in Italy we had one of the worst lockdown all over the world. And so you know that all scientific organization that we had were in agreement on the need to do a suspension, very urgent, of all elective surgery. And of course, it was reflected even on our hysteroscopic activity. Because you know that during the lockdown, the only stereoscopic procedures that were allowed to be performed were emergency and the procedure in which we could potentially worsen the patient's outcome. And we will go deeply in details. You see that, of course, the procedure in which the delay could potentially worsen patient's outcome are the procedure in which probably there is a suspicion of gynecological cancer, so most of the time endometrial cancer. We didn't modify our technique. We use grasping forceps to do biopsy, or we are using in the last months the tissue removal device in order to perform a sort of visual DNC. So we don't prefer blind technique, but always under vision, and we can collect a lot of tissue in order to have a proper histological diagnosis. The only stereoscopic emergency that were allowed were the cesarean scar pregnancy. And in the last year, we are conducting a randomized controlled trial in our institution comparing the traditional blind evacuation with cannula Karman with our hysteroscopic technique using a 5 French bipolar resectoscope. 2 injections at day 1 and day 4 of methotrexate, and then we use the surgical technique. In this video, of course, you will see the technique with the 15 French bipolar resectoscope. You first remove the intracavitary portion of the gestational sac. We were lucky in this case that I did not cut immediately the amnios, so you could see the amnios and the embryo. The embryo, of course, is dead because of the injection of methotrexate. And as soon as you have removed the amnios, you have to identify the umbilical cord, which connects, of course, the embryo to the early placenta. And so we resect this umbilical cord for 2 reasons: that we have the embryo goes away in the cavity, so you are not scared of working with an embryo just next to your loop. And then you progressively continue to resect the gestational sac. Of course, the cavitary portion is quite easy. It's a little bit more challenging when you identify the base of the umbilical cord, which means that here there is the implantation of the pregnancy. And of course, if you have a very safe and effective bipolar technology, you see that you can cut tissue. Sometimes, in order to be safer, mostly when you are going to resect the base, the site of the implantation of the pregnancy, you don't need to use all the depth of the loop. You see that I can also use only 1-2 millimeter of the depth of the loop. And this part is a little bit challenging because, of course, the residual myometrial thickness generally is 1 to 3 millimeter. In this case was 2 millimeter. And so it can bleed a lot. But we think that the results of our randomized control trial probably will show that removing of the cervical pregnancy and cervicoismic pregnancy is better under vision. You know that because it's been published on GMIG that a group of experts has tried to evaluate the impact of COVID-19 pandemic on hysteroscopic procedures. But mostly we have tried to give some recommendation in order to perform safe and effective hysteroscopy in COVID times. And in the last 2 weeks, I can tell you that we are slowly going back to our pre-COVID standard. That means that our elective hysteroscopic surgery is dramatically increased. Some precautions needs to be taken in the office, where of course we limit the number of team members. We cannot have students, we cannot have visitors, we cannot have husband or next to the lady or medical student. Of course, we have to wear personal equipment. In this case, for example, was a lady with severe metrorrhagia, and we perform our diagnostic hysteroscopy. The patient is awake, no analgesia, no anesthesia. A 1.3 centimeter G1 myoma was detected in the cavity. It's better to choose the appropriate device. You could use the bipolar resectoscope, the bipolar electrodes, but even in this time, we prefer to use the tissue removal device because despite the risk of virus dissemination with smoke is very, very low. Hysteroscopy is not an aerosol generating procedure, but if you have the possibility of using this tissue removal device is much better. You work in a safe environment and they cut very well. In this case, for example, because there is always an intramural portion of the myoma, and we switch back to the Betocchi hysteroscope, and using miniaturized 5 French scissors, blunt scissors, we enucleate the intramural portion of the myoma. I think that there is no best technique or technology in every surgery, but the combination of different technique probably is the future. In this case, we use tissue removal device and standard mechanical instrument. And with this very robust forceps, we remove the base of the myoma, and you see that the final effect is a perfect fovea when there is no bleeding and no sacrifice of healthy myometrium. And you see, this is the final view that we had. And the lady is satisfied because when you can do surgery and she's awake following the procedure. Even in the operating room, of course, some precautions are important. So please prefer regional anesthesia. And you should avoid the intubation. Of course, you know why. Always, even in the operating room, restrict the number of team members to minimum. In this case, I was supposed to do a fundal type 2 myoma, but the hysteroscopy was done in December. In 3 months, things can change. And with hydromassage technique, I understand that now it's a type 3 myoma, just slightly in contact with the endometrium, and this is a fundal myoma, so the most challenging type of myoma. In this case, we cannot use tissue removal device, so you need to cut, you need electrosurgery, so we prefer to use our 15 French bipolar resectoscope. So this 15 French resectoscope do not need that you have to dilate the cervix because it's 5 millimeter. You first resect the endometrium, which covers the myoma, then the slightly intracavitary portion of the myoma. What is important is that if you use a device that can generate smoke, it's very important that you have negative pressure applied to the outflow channel and so connected to the pump that is present in your station. Then you see that you cut a little bit more of the volume of the myoma because you want to identify the pseudocapsula. So we are working at intramural level of the uterus. That's why we need some cold loops in order to identify first the cleavage plane in between the pseudocapsula and the myoma itself. So are not electrified loops. It means that even if you create a perforation, it's not very dangerous, but you don't create any perforation because if you use very hard movement with your hands, but always respecting the anatomy, so always working inside the pseudocapsula and not outside, like we do in robotic or laparoscopy, And then, for example, you can even switch to this knife-shaped loop in order to hook and lacerate all the connectival bridges which join the myoma in the bed of the fovea. And as soon as the intramural portion of the myoma becomes intracavitary, so you can switch back again to your standard loop electrified, so it means that you use electrosurgery, and then you are going to do the slicing of this intracavitary portion. But what is important is that you always have to orientate the convexity of the loop towards the lesion. So it means always from the pseudocapsula to the intracavitary portion of the myoma in order to be safer. Because when you work in hysteroscopy at the intracavitary level, it's all, of course, much safer than when you work inside the wall of the uterus. The cleaning of the base of the myoma, of course, can be a little bit challenging, mostly when you are working 2-3 centimeters within the wall of the uterus. But I think that even for type 3 myoma of limited size, like 2.5-3 centimeters, it's the best option. Of course, you have to check the fluid balance intraoperatively. So during surgery, in this case, we had a little bit less than 2 liters. And you see that if you use saline, there is no problem according to the AAGL guidelines. So you clean the base of the myoma, and you see that the final results, it's very good because you see where the tubal ostium is, and you have a hole in the fundal area. So we are 2.5 centimeters inside the fundal uterine wall. And I'm sure that in 4 to 8 weeks, if you do a diagnostic hysteroscopy, you are not going even to identify where the myoma was. And this is the final effect. I hope I was in time, and thank you very much for your attention.
Wonderful.
That was terrific. The visualization has certainly improved in 30 years, I have to say.
Kate, there is a thing called a hysteroscope. It really but he does it very well, especially with that 5-millimeter loop. That is amazing. Because just as you know, Attilio, I don't have to speak. I'll be very complimentary. That is a fairly delicate loop, and you can break it very, very easily.
Yep. So I think that mostly in this time, we are just trying to use much more the tissue removal device, because despite hysteroscopy is considered very safe procedure, not virus dissemination through genital fluid, as has been shown in a couple of papers from the Chinese. There is the risk of having bubble coming out in the atmosphere, so releasing the virus in the atmosphere, it's zero. Of course, it's not been proven, but when you use smoke generating device, it's very important to have a negative pressure on your outflow channel, and so you remove all the smoke and liquid tissue that is inside the uterine cavity.
Well taken. Attilio, I have a question for you. Okay, I have to stop you. Is that because I think it's a very important point. That first the C-section ectopic was wonderful, and I have always been done those laparoscopically, because they and my experience has been, and I've done a number of them now, is that in the process of just touching the myometrium and open it, just it's almost ready to rupture by the time we get in, and these are early cases. How did you know how to go, what depth you were comfortable with?
You know, in hysteroscopic surgery, the control is the control of the hysteroscopies. If you use ultrasonography or laparoscopic control, you cannot avoid perforation. Sure. So that's why, as I show in this video, when you have a very small loop, and you don't need to use the 4-millimeter depth of the loop, but even 1 to 2 millimeter, and you slightly resect the tissue. Of course, we have even ultrasonography inside the operating room just to check the thickness of the residual myometrial over the cesarean scar pregnancy. But even if you leave a little bit of gestational tissue inside the pouch of the cesarean scar, nothing happens, because of course you you are creating, so you have removed the embryo, you have removed 95%, and you will have an hematoma in this patch. 99% of cases, there is an hematoma, but this hematoma is quite safe when it is formed in this patch because it creates a sort of control of the bleeding. And up to now, I can tell you, but touching wood, that I didn't have any perforation, but the alternative, not many people are able to do laparoscopic removal of the cesarean scar pregnancy. Most doctors do with blind dilatation and curettage or removal with Karman cannula. So I think that if you are able to see, and what is important is the very early diagnosis, to do the operation less than 10 weeks. This is very important. So to have
are you recommending treatment of the isthmocele post-surgery then?
No. There is no study which has shown that the treatment of isthmocele can prevent the occurrence of ectopic pregnancy in the cesarean scar.
So what age, what gestational age?
I tell you, even more, that the cesarean scar is protective for the development of a pregnancy there. Most of the pregnancy in isthmic region, when there is a cesarean scar, are on the posterior wall, not inside the cesarean scar. So on the posterior wall, the real cesarean scar pregnancy is what I showed now inside the patch of the cesarean scar.